Next speaker is Dr. Anshu Gupta. She is a professor in Lady Hardinge Medical College and associated hospitals. Her area of interest is pediatric anesthesia, regional anesthesia, and ultrasound guided nerve blocks. And she'll be talking about pediatric neuraxial anesthesia. Over to you, Dr. Anshu.
Good morning, everyone. I welcome you to this session of pediatric neuraxial blockage.
Pediatric neuraxial anesthesia. At this outset, I would like to thank MD Kaur ma'am and Nija ma'am for providing me this opportunity. I bring greetings from Lady Hardinge Medical College and associated hospitals, Delhi. This is a very important topic from examination point of view, as you may be asked many questions from it, like anatomical, physiological, and pharmacological features which are different from adults in pediatric patients and their clinical importance. Then techniques and common practices may be asked, and adjuvants used and the neuraxial blockade drugs may be asked, or you may be asked about the role of ultrasound in pediatric neuraxial blockade. So what are the indications for central neuraxial blockade in pediatric patients? It is used for providing anesthesia and analgesia in abdominal, inguinal, and lower extremity surgeries as an adjuvant to GA, for providing postoperative analgesia, and for preemptive analgesia, which may be established before the start of surgical procedures. Spinal anesthesia holds a very special importance in pediatric patients because many children are premature children, and such premature infants or neonates are very prone for postoperative apnea. And smaller is the gestational age at birth, more are the chances of postoperative apnea in such children. So it can be used as a sole anesthetic technique, which decreases the chances of post-apnea, but then we have to avoid the intra-op sedation in these children when providing the spinal anesthesia. There are also certain more other indications of spinal anesthesia where it holds a very important place, because in such cases the general anesthesia is not to be given or avoided, like in patients with family history of malignant hyperthermia, children with neuromuscular disease where respiratory reserve is very less and would be affected by general anesthesia, in children with significant neonatal history of intraventricular hemorrhages or necrotizing enterocolitis, children with chronic pulmonary disease where airway manipulation may pose a significant risk, children with congenital heart disease and airway anomalies, and children in emergency who come full stomach, spinal anesthesia may hold a very special place. There are certain absolute contraindications to neuraxial blockade, like severe coagulation disorders like hemophilia or DIC. But remember that coagulation time normally is slightly prolonged in children, so slight prolongation of coagulation time may not be considered as a coagulation disorder and a contraindication to neuraxial blockade. Other contraindications are severe infection or septicemia, like septicemia or meningitis in children, or when there is increased ICP because of increased intracranial tumor, or there is an allergy to local anesthetics, or the child is on certain chemotherapies, or there is uncorrected hypovolemia, or there is some lesion at the site of puncture like angioma or dystrophic tattoo. All these are the contraindication to neuraxial blockade. And always remember that parental refusal is a non-medical absolute contraindication, so always discuss the procedure with the parents and take consent before proceeding for the neuraxial blockade. Now, I would like to emphasize the fact that children are different and are not to be considered as small adults, as there are many differences in their anatomical features and their in physiology, which makes them different, and so the technique used, the amount of drug, everything varies in children and is different from adults. Now, in spinal cord, there are certain changes which are there in neonates as compared to adults and infants. This spinal cord occupies the entire spinal canal in children, and later the growth of vertebra exceeds that of cord, so spinal cord is shifted upwards. So at birth, dura mater, which ends at S3, S4, at 1 year of life, it is lying at the S2. So when dura mater is at S3, S4, which is a very lower level, so there is a possibility that we might puncture the dura mater while giving the caudal anesthesia also. Also, the adult level of cord, lower end of the cord, is achieved at 1 year of life, which is L1. In neonates, the cord is lying at L3 or L4, as you can see in the diagram. And as the child progresses, it becomes higher up at the L1 level. So it holds a very special importance that lumbar puncture in neonates and infants is to be performed at below the cord, cola medullaris, that is at L4, L5 or L5, S1 interspace to avoid the injury to the spinal cord. And epidural approaches should be above L3 as far as possible. Also, as I've already discussed, due to projection of dural sac, there is risk of inadvertent penetration of dura mater during caudal and epidural anesthesia. So we should check for CSF reflux during caudal and epidural and favor the lower approaches to the epidural space. Then another difference is that the ligament flavum is much thinner and less dense in children, which leads to very low resistance, and there can be dural puncture during epidural anesthesia and wet tap may occur. Also, the bones of neonates, including vertebrae are soft and cartilaginous. So sharp needles can easily transverse them, as cartilage offers very little resistance to their penetration, and there may be no feel of loss of resistance. So there are chances that we may damage the ossification nuclei, or there may be bacterial contamination which may occur because of this damage, and so there can be further growth of bone and joint which may be hampered. So children, the growth is very important, and there is a risk to damage of ossification nuclei. And another, because of soft laminae which are cartilaginous, paramedian approach should be avoided and midline approach should be preferred in children. Also, there is lack of fusion of sacral vertebra. Because of persistence of this sacral intervertebral space, even epidural anesthesia can be performed through intervertebral sacral approaches, which is easily done in children. Catheter can be threaded upwards up to lumbar or even thoracic level. And after 8 years of age, the sacral hiatus becomes small and caudal becomes difficult in children. Also, there is another very important thing, that there is delayed development of curvatures of spine in pediatric patients. So cervical lordosis occurs from 3 to 6 months of age, and lumbar lordosis develops up to 8 to 9 months of age. So because of lack of this thoracic kyphosis, it facilitates the upward spread of the drug and higher level of sensory blockade. And secondly, we have to remember that up to 6 months of age, same orientation of epidural needle is needed, whether we are performing at a lumbar level or slightly higher level in such patients, because there is no curvature present. Then another important thing is that the toofier or intercristial line, which is the line joining the two anterior superior iliac spine, is at the level of L5, S1 interspace in children, unlike adults or bigger children where it is at the L4, L5 level. So lumbar puncture can be safely performed below this toofius line. Then there are certain physiological differences leading on to the pharmacological differences. There is delayed myelination in children, and myelination process begins during fetal period, which is not finalized before the 12th year of life, which leads to easier intraneural penetration of local anesthetics. So what happens is onset time of is shortened, and the diluted local anesthetics are as effective as the concentrated anesthetics. In fact, twofold diluted local anesthetics can be used. Now also there is due to delayed myelination, there is increase in duration of blockade, which is reduced in children, because in adults there is trapping of local anesthetic within the myelin sheath and there is progressive release. So lack of myelin leads to decreased trapping of local anesthetic, and so duration of blockade is also reduced. Also there is increased cardiac output and heart rate. So there is increased systemic absorption of drugs, so which again decreases the duration of block. Also they require larger volume of local anesthetic because there is loose attachment of sheaths and aponeurosis to underlying structures, which leads to increased spread along nerve paths with danger of sometimes penetrating the remote anatomic spaces and blocking the distant nerves. Also, besides decrease in local anesthetic dose in epidural, there is also increased chances of systemic toxicity with repeated dosing. This is so because of many reasons, like there is enzymatic immaturity in pediatric patients, which leads to slow metabolism of local anesthetic, increasing their half-life and accumulation of the drug. Then there is low plasma protein concentration of human serum albumin and alpha-1 acid glycoprotein, which leads to competition at their binding sites, which leads to increased plasma concentration of free fraction of drug, leading to greater danger of systemic toxicity. Also, these patients, pediatric patients, have increased extracellular fluid volume, which leads to increased distribution volume. So there is increased concentration maximum which occurs after single injection, but accumulation occurs with repeat or continuous injections. And this is also the reason for higher dose requirement in subarachnoid block, because there is increased ESF volume and distribution volume in pediatric patients. Now also another reason for accumulation of drug and is that there is high hematocrit value greater than 70%. Why this affects is that in adults there is entrapment of local anesthetic, thus lowering the peak plasma concentration and increasing their secondary release, and therefore increasing the life of all anesthetics. But this effect is minor in adults because the hematocrit values are not so high. But in pediatric patients, because hematocrit values are high, so this entrapment cannot be ignored and there is secondary release and prolonged half-life. In infant, there is physiological anemia, which decreases the red cell storage and thus nullifies the effect of systemic toxicity of local anesthetics. Also remember that in children, there is increased fluidity of epidural fat, which is less localized. So this leads to decreased local anesthetic fixation and increased spread in infants within epidural space. So the consequences of all these facts are that there is shorter onset of action, shorter duration of action, more extended longitudinal circumferential spread of local anesthetic, and there are increased chances of systemic toxicity with repeated dosing, and excellent blockade after caudal anesthesia can be performed up to 6 to 7 years of age. Also in pediatric patients, there is increased local anesthetic doses requirement for the spinal block. But this is so because, first of all, their CSF volume according to their body weight is very high. It is 10 ml per kg in neonates, whereas in adults it is only 1.5 to 2 ml per kg. So one is that their CSF volume per kg body weight is high. Another thing is that there is leakage around spinal nerves and there is high CSF turnover rates, which leads to shorter duration of spinal anesthesia in pediatric patients. So dose requirements are high. As the child grows, the dose requirement decreases and there is increased CSF turnover, leading to shorter duration of spinal anesthesia lasting only up to 60 to 90 minutes. Also remember that children experience greater pain than adults. It is because their descending inhibitory pathways are immature, which leads to unmodulated inputs to ascending spinal pathways, leading to poor pain localization. Regarding local anesthetic used in central neuraxial blockade, lignocaine, chlorprocaine, and mepivacaine are preferred for outpatient surgeries, and for inpatient surgeries, ropivacaine, levobuprivacaine, and bupivacaine are preferred. L-enantiomas like ropivacaine is recommended to be used for continuous infusion because of lower cardiac toxicity compared with bupivacaine. And ropivacaine can achieve a differential blockade. Now, blockade has a limited myotoxicity in compared to bupivacaine. Now, use of adjuvant regarding neuraxial opioids, there is elimination half-life which is increased in neonates and infants. Morphine reaches its peak plasma concentration in 10 minutes. But this concentration is very low, so unable to provide any clinical relevant analgesia. But when this epidural injection reaches CSF, its concentration is very, very high. So it takes 12 to 24 hours to decrease below minimal effective concentration, which leads to progressive and delayed respiratory depression. So short-acting lipid-soluble opioids can be used, but they do not provide significant post-op analgesia unless repeated injection or continuous infusion is given. In subarachnoid blockade, we can use clonidine, fentanyl, or morphine as an adjuvant. Epinephrine in 5 mg per liter or 1:2 lakh concentration can be co-administered with local anesthetic, which decreases plasma peak concentration and prolongs the duration of blockade. And it is used as a test dose for detection of accidental IV injection because children are sensitive to arrhythmogenic properties of epinephrine. But for test dose, it is said that neuraxial epinephrine may cause spinal ischemia if it is in the if epidural catheter has migrated into the CSF. So it is recommended to use lower concentration of epinephrine, 2.5 mg per liter or 1:4 lakh when it is administered to neonates and infants. Regarding clonidine, which is an alpha-2 adrenergic blocker drug, it increases the duration of neuraxial blockade and prolongs the post-op pain relief without causing any hemodynamic disturbances and produces a light sedation for 1 to 3 hours postoperatively. Its clearance in neonates is approximately 1/3 that in adults because of immature elimination pathways, and also it can cause respiratory depression, so it should be avoided during first 6 months of life. Now, regarding additives and doses in pediatric neuraxial blockade, morphine can be used in epidurally in approximately 30 mics per kg, and fentanyl epidurally can be used in 1 to 1.5 microgram per kg. Similarly, clonidine 1 to 1.5 microgram per kg, and ketamine can also be used. Regarding spinal anesthesia technique in children, amla cream should be applied before lumbar puncture and IV at the lumbar puncture site and the IV cannulation site 1 hour prior to arrival in the operating room. And if not done, then local anesthetic should be given before performing the spinal anesthesia. Now, sedation should be avoided in preterm infants because of risk of apnea. Older children may require pre-medication to overcome the separation anxiety. Oral midazolam with ketamine or atropine can be given for sedation. Now remember that fluid preloading is not required in children because they have immature sympathetic system and smaller vascular bed in lower extremities. And pulse oximeter and NIBP cuff may be applied in the lower extremity to avoid the disturbances to the infants during the surgery. Patient may be performed in sitting as shown in the picture, or it can be lie down in the lateral decubitus position with flexion at neck and hip joint. But remember, in neonates and infants, that care must be taken to avoid extreme flexion of the neck. As you can see here, that neck has been kept extended so that there is no upper way obstruction, which otherwise may lead to hypoxia. A 45-degree head tilt may help by increasing the CSF pressure in infants. Now, in infants, L4, L5 or L5S1 space is identified and midline approach is preferred. Technique, a short length spinal needle of 20 to 25 gauge is used, and it should be noted that shorter pediatric needles are preferred because if we use bigger needles, they may break in case of movement during spinal anesthesia, and the precision will not be achieved with the larger needles. And also, there is no very less incidence of PDPH in children, so distal end of the needle does not matter, and it is not influenced by the design of the tip of the needle. What is more important is the distance of the tip of the needle from its distal orifice, because there might be extradural leakage if the needle is just lying at the starting of dura mater, so it should be taken care of. And one should remember that POP may not be felt due to soft ligamentum flavum in pediatric patients, and barbotage method is not to be used because there are chances of high spinal which may occur. As we have discussed, there are increased local anesthetic doses for spinal anesthesia, so we can give 0.5% bupivacaine isobaric or hyperbaric in less than 5 kg, 0.5 to 0.6 mg per kg, 5 to 15 kg, 0.4 mg per kg, and further lesser dose in greater than 15 kg of 0.3 mg per kg, which lasts for 30 to 180 minutes. Similarly, ropivacaine 0.5% may be used in the 0.5 to 1 mg per kg in the less than 5 kg, and increasing to the dose of 0.5 mg per kg in 5 to 15 as well as in greater than 15 kgs of the patients. Lumbar epidural analgesia, which can be provided in single shot by catheter insertion or patient controlled epidural analgesia can be given. It is usually performed in anesthetized patient via midline route at L2 to L3 space, which is the lower limit of conus medullaris. Technique is same as in adults. Remember, medium for selection for technique for loss of resistance technique can be both air and saline, but air is more sensitive and preferred especially in neonates and infants. Distance from skill to epidural space is correlated with patient's age and size, because this is important because there are very high chances that epidural needle may enter the dural space and puncture the dura mater, because there is less loss of resistance and thin ligamentum flavum. So it is essential that we pre-calculate according to the age and weight of the child the expected epidural space, and then we proceed. It is usually calculated as 1 mm per kg for children between 6 months to 10 years of age. Remember, whenever catheter is inserted, it should not be more than 3 cm to avoid the bucking, knotting or migration. Also, one more important fact is that in children, the markings on the epidural catheter are at 0.5 cm, not 1 cm. So you should be careful in calculating. And for approximately 0.1 ml per year of age is necessary to block 1 neuromere. And usual volumes range from 0.5 to 1 ml per kg. And upper limit of sensory blockade achieved by this is T9 and to T6. Now regarding test dose, we have already discussed we can use epinephrine 1:2 lakh or 1:4 lakh, 5 microgram per kg or 2.5 microgram per kg. But again, the effect of this epinephrine may be masked by the anesthetic agents and it may not be visible properly. So what is recommended is use of fractional test dose or very slow injection of local anesthetic dose under hemodynamic and ECG monitoring, so that there is patient safety. Epidural dosing can be done as an initial bolus dose followed by either continuous infusions or repeated injections every 6 to 8 hourly. We usually take solution of 0.25% bupivacaine with epinephrine, or you can use adjuvants like fentanyl, sufentanil or clonidine. But these adjuvants are to be avoided in children less than 6 months because of chances of accumulation and systemic toxicity. And we usually give in the dose of 0.75 ml per kg in less than 20 kg and 8 to 10 ml in 20 to 40 kgs of children. Then continuous infusion can be started with bupivacaine or ropivacaine in less than 4 months at the rate of 0.2 mg per kg per hour of 0.125% solution, and in 4 to 18 months of 0.25 mg per kg per hour of 0.125% solution, and in greater than 18 months, slightly higher dose can be taken 0.3 to 0.3575 mg per kg per hour. Or sometimes we can use 0.0625% solution also for infusion depending on the post-operative requirement. Any one additives can be selected out of fentanyl, sufentanil, morphine, hydromorphine or clonidine. Now, ropivacaine can also be given at the same infusion rates as bupivacaine, but in concentration of 0.1% or 0.15%. 15% can be taken. Repeated injections can be given 6 to 8 hourly in the dose of 0.1 to 0.3 ml per kg for bupivacaine, or for ropivacaine 0.15% can be given. Now, caudal anesthesia, the sacral hiatus is identified. For the technique is that you identify the sacral cornea, which lies near the posterior superior iliac spine, and a triangle is formed by the line joining the two sacral cornea and the gluteal cleft. And this line joining is the it divides line joining the base of the triangle to the apex is the divides it into two equilateral triangle, and it is the point of the sacral hiatus. A needle is inserted at the 45 degree and a pop is felt, which is the piercing of the sacrococcygeal membrane. For caudal anesthesia, we use Armitage regime, according to which we give 0.5 ml per kg for sacral blockade, 1 ml per kg for lumbar dermatomes, and 1.25 ml per kg is injected for slightly higher levels. Caudal anesthesia can be performed even ultrasound using USG guidance, which is a very more definitive short technique. For this, we place the ultrasound probe in the transverse position to identify the caudal space. Like you can see, this is a frog eye eye. These two are the sacral cornea. This is the sacrococcygeal membrane which is to be pierced. This is the base of the sacrum, and this is the caudal space between the two hyperechoic lines. You can see in this video the two sacral cornea, sacrococcygeal membrane and the base of the sacrum, and this is the caudal space. Now we place the probe now longitudinally so that needling can be done along the axis of the probe. So we place the probe longitudinally and we identify the sacrococcygeal membrane. And here we can see that this is the dura mater and this is the sacral caudal space where the needle is inserted. This is the video where you can see that this is the dural sac, this is the sacrococcygeal membrane, and this is the caudal space where needle is to be inserted and the drug is to be given, and we have to watch for the anterior displacement of the space. Ultrasound guided epidural technique is not very popular because there are certain limitations to the technique, as it is hard to localize with the probe and the tangential relationship of the needle, and assistant is required for the catheter placement. And one should remember that saline is to be used for LOR technique to facilitate ultrasound imaging if done epidurally, ultrasound guided epidural insertion. And epidural, if it is to be done, then it can be used for localization of the epidural space, and later needling can be done. So to summarize, we would like to say that neuraxial anesthesia in pediatric patients is a helpful technique. It To perform this block safely in pediatric patient, it is mandatory to know the anatomical and physiological differences between pediatric and adult patients. Correct technique of procedures should be learned, and safety features and correct doses of LA, local anesthetic and adjuvant is very, very important. And along with the block, during and after the block, close monitoring of ventilation, oxygen and circulation is very important. Thank you for the patient listening. Have a
Thank you, Dr. Anshu. It was a well-covered topic. I don't think there are any questions in the chat box. So thank you both the speakers.
Thank you very much for providing us the opportunity. Thank you.
Thank you.
Thank you so much, Dr.
Thank
Akhilesh.
Thank you, sir. And thank you to both the speakers for such a wonderful presentation. Moving on with the next session on pediatric anesthesia, I would like to invite the chairperson for this session, Dr. Suniti Kale. Ma'am is consultant and professor and is the ex-head of the department at Vardhman Mahavir Medical College and Safdarjung Hospital, New Delhi. Ma'am's area of special interest are pediatric anesthesia, airway, and robotic surgery anesthesia.
Can I start?
Yeah. Over to you, ma'am, for the proceedings of the session.
Okay. Thank you so much. Good morning, everybody. And we are going to continue with the session on pediatric anesthesia. And we have two important topics coming up in the next 1.5 hours. My first speaker today is going to be Dr. Raylene Diaz. She's an associate professor and head of the department at the GS Seth Medical College and Edward Memorial Hospital, Mumbai. She, other than MD and DMB in anesthesia, she's also DM in pediatric anesthesia. So I think she's only working in pediatric anesthesia setup. Her areas of interest are, other than pediatric and neonatal